panelists, I want to welcome you all and also to tell you that there is traffic jam leaving at this time. So you might as well stay and listen to the session in full because trying to get in the jam, you might actually miss boss. So you rather stay a little longer than waste it in the traffic. But otherwise, we have a very important session for you today. Allow me to first recognize Director Daniel Chawainze, who is Director of Public Health. We are happy to have you. Welcome. I also want to welcome, I had the protocol up there, so I want to join it to the extent it is also applicable here. Please, you're all welcome in your respective capabilities and capacities. I want to start by telling you what we are here to launch. So there's a small book in my hand. It's available online if you got the Lancet. Lancet is a journal that publishes health research, especially Lancet Global. This is an issue that was published 17th February. And what it has is what we call the Lancet Global Health Commission for Medical Oxygen Security. Now, there are many words in there. I'm going briefly to, before I call my presenters, to indicate that this session has two parts. The first part is going to be presented by my colleagues, and allow me to introduce now Dr. Fred Kitutu, who is a senior staff at the Makerere University and School of Pharmacy. But in this regard, he was among the executive committee members that made this Global Health Commission report. I'll explain what these committees mean. Dr. Fred Kitutu, you are welcome. You can join me in this welcoming him. Oh, there is already many of the things I want to say are on here. I didn't notice, maybe I need not to repeat, but allow me also to welcome the commissioner on the Global Commission. I'll tell you what a commissioner means shortly. This is Dr. Redet Waknet from Addis Continental Institute for Public Health in Addis Ababa, Ethiopia. You're welcome. Please, you can join me on the panel here. Although eventually, I don't know, maybe you can sit, have a free, because you may want to see the screen when the other one is presenting. We can use the former chair's seat here. I don't see Fred. Fred, can we take your chair here? Wonderful. So, what is this Global Commission on Medical Oxygen? First of all, maybe the first question is, what is a Global Commission report? So, the Lancet, and particularly Lancet Global Health as a journal, has commissioned 3 other Global Commission reports. Usually these are reports that try to capitalize and put together evidence in a way to generate or pull together the necessary information to address an issue of public concern. So they've published many, and this one is dealing with the issue of medical oxygen and its security. It also is a way of pulling together the known science through methods of review, inquiry, or response. Sometimes, in most cases, it's multidisciplinary, and it is usually trying to transform an issue so that all actors, all players involved can be part of it, or at least can know what to do. This particular one is global in nature, meaning that we are not targeting a particular country. We are launching it here in Uganda, yes. But there was a launch back in May, which was for the, is it May or March? For the global community. But we wanted to launch it here in Uganda, and there are also good reasons for that, which I'm going to go through. Why a commission on oxygen? And medical oxygen in that matter. We all know we breathe oxygen, all of you here. I don't know how many liters you've already taken since you entered in the room. But NCDs, as you heard the theme of this session, of this conference, among the many conditions we are dealing with in NCDs, they require oxygen as one of the treatments. We have people from the Lung Institute here. Any member? So if we have a whole institute in the College of Health Sciences, the Lung Institute, part of what it does is to deal with those diseases that actually do affect how we get oxygen from the air, from the room, and make it available at the tissue level. And then a member from the what is the Heart Institute? Okay, we also have a Heart Institute. That does more than pumping. It makes oxygen available from the lungs all the way to the tissues. Someone who is specialized in some organs, like the brain. I see my colleague who deals with intensive care. Nice to see you. Dr. Kwizera, welcome. He's an intensivist. When they put somebody to sleep for some reason in theater, or somebody is in intensive care, oxygen becomes the main therapy. I don't want to belabor this, but just to let you know that in medical care, oxygen is routine. But the reason we are here to launch this report is although it is routine and it's been in practice since almost more than 100 years, is that our health systems have never been very prepared to make this service available in a way that can guarantee its use and outcome. How many of you lived through COVID pandemic? Okay, I was hoping all hands would be up. Oh, who didn't live through is not, of course, in the room. So the point here is, if you lived through the COVID pandemic, you must have seen the role of oxygen at play. In whether countries big, or we call them small, or developed, or underdeveloped, high income or low income. Among the pictures that I still have in my mind is what was playing on CNN, BBC, and other countries like Al Jazeera, particularly from India, because there was a lot of, I think India is a big country, and I think they had a lot of population moving from urban center to go to the village because of the lockdown. And they created a very big transmission. But I remember seeing people getting onto this cylinder literally in a rationing way. This one is gasping, but the other one is gasping more. So first transfer to that one. And literally you could see that the dignity of life was really at its lowest. I had the pleasure of being on the scientific committee, so Micah had a sticker during COVID, so I had to move around. Many of you may not have had a sticker to move around. But on the road, we were with the borders, because they were allowed to also move. But there was a time when they were only carrying oxygen cylinders. Every border was moving with oxygen cylinders. You know why they were taking them? They were taking them into homes. I ran a hospital, I'm the chair board in Zambia Hospital. All our cylinders disappeared because the demand for cylinders was so high. And we also now struggled as a hospital to keep giving oxygen to our patients as we are losing all the cylinders too, those who need them at home. But what I'm describing is a chaos out of which this report comes to actually document lessons, but also to see how do we try as countries, globally, Uganda and every other, to make oxygen more stable, become a permanent pillar of the health system, and delivered effectively. So in that regard, allow me then to welcome my presenters. I hope now it is very clear. But the reason we are launching here, which I think I should have said also, our Minister of Health and Dr. Chavainza, who was here in the room, actually did one of the initial steps or a set of the action. This report comes out of a commission. I think Fred will present more on that. But that commission was started in, you know the, what is it called? The Galloway Guest House there? So Galloway Guest House, so I remember it was Fred here. It was Kwizera. We had a colleague visiting from Melbourne. And in 2022, we were trying to audit what we are doing. We are doing a small study on oxygen. Then we said, okay, we are doing this study, but literally the whole world has had this shock. Can't we do something? So the first idea was to think of a global commission. When members started to connect and form, another idea came up. In 2003, there was going to be a World Health Assembly. So we said, can't we target the World Health Assembly and put this thing on the agenda and have a WHO resolution to make oxygen essential? We were joined by so many people. They cut the whole story short. Our minister here, the minister in Ethiopia, and the reason we have our sister from Ethiopia, the minister from Bangladesh, agreed to champion this work. So our job was to provide the information in that background, and they made the resolution pass as Resolution 76.3 in 2023. And our minister contributed to that job, and this part now is to provide the evidence of what that resolution needs to, or what the evidence they needed to make oxygen become a permanent fixture in the health system. Well, with that, I hope you now understand why we are here. The ask after this is that we want to move this report from being a report to making a difference in the communities where you are, in Uganda at large and globally. So we hope that after this, listening to the rest of the paper, you can also join, and the panel, you join the ambassadors to make this report make a difference. That is the reason we are launching it here. It's also been launched in so many other countries. With that regard, let me invite Dr. Freddy Kitutu to take us through the first part of the presentation. Thank you.
Thank you very much, Prof. Sengova, for the kind introductions. We shall deliver the presentation together. I'll invite the Commissioner, Dr. Redet, to join me. And we'll start with a brief history, but also the summary of the report, which appears on top. The Commission conceptualized oxygen therapy as life-saving for people with acute illness, life-sustaining for people undergoing anesthesia and surgical care, and life-enhancing for people with chronic respiratory failure. Oxygen, therefore, is an essential medicine and an essential service that requires a systems approach in its delivery. Little many of us may not know, but oxygen as a compound and as a medicine has been in existence for over 254 years. Discovered in 1771 by a Swedish Carl Wilhelm Scheele, who was a chemist and a pharmacist as well, and discovered it by mistake while doing some of his experiments. Fire air. Of course, there is a bit of controversy about that because he published his findings in 1777. Before publishing, other scientists had also written about it, but he's credited with discovering it. 10 years later, or about, it was first used in managing tuberculosis. And about 100 years again in the US, 1885, a young pneumonia patient was treated with oxygen. So it took about a century before it started to be recognized as a medicine. And then, of course, along the timelines, we've also indicated other significant medical discoveries, smallpox in 1796, X-rays in 1895. But by and large, until 1955, people who needed long-term oxygen therapy were not yet using it until it was pioneered in Australia, and it's only due regard that part of the commissioners and the secretariat were actually from Australia. And then pulse oximetry, which is one of an important services in oxygen therapy, came into use in 1974, so much later. But of course, for many people in the room, 74 is ancient. But since 1974, we know that a lot of patients still don't have access to that. This is the summary that Prof was taking us through about what commissions are, and this again is a commission that was born out of COVID-19. This summarized the team that painstakingly worked over 2 years, to put together evidence and respond to some of the questions, identify the unanswered questions, some of whom the members are in here. We have the commissioners already introduced, the executive that I served on, advisors. We shall see Dr. Arthur Quizera, fresh from defending his PhD with us. He's standing at the back. And many other colleagues from Clinton Health Access Initiative, UNICEF, who formed part of the different arms. So the advisors, the collaborators, over 100 institutions and individuals who came together to put together this report. We will now summarize the key findings, and I'll invite Radiate to get us through the first set of findings.
Okay, thank you. It's an honor to be here. So I'll walk you through oxygen need and oxygen coverage. So who needs it, how much is needed, which conditions require more oxygen, and also oxygen coverage. So I'll be presenting some of the staggering numbers when it comes to oxygen delivery. So each year, it's the Lancet Commission's report that 374 million people need medical oxygen, and majority of them, 82%, live in low and middle income countries. And you can imagine how emergencies like the COVID-19 pandemic would completely disrupt health facilities, and this would impact the healthcare that we provide for our patients. So, as you can see from the figure right there, the circles represent proportionally the oxygen need there is in regional differences. You can see right here that in Southeast Asia and Pacific and also Sub-Saharan Africa are the majority of the oxygen need comes from. And it's about 4.6 billion cubic meters that is required for acute medical and surgical conditions, and about 3.2 billion cubic meters for COPD. So to get to this figure, there was a rigorous research activity that has been done, and I think you would be able to access this through the report. So we've listed here on the table there that the different conditions that we have said are acute medical conditions and how this was translated to oxygen need. So majority of the cardiovascular, respiratory infections, neonatal disorders, trauma, requiring about 105.4 million, excluding COVID-19, that is, because COVID-19 by itself has significant oxygen need when we were able to witness that. And surgery, majority of which is unmet, is actually about 259 million people were in need. So we have talked about acute medical and surgical needs and chronic conditions. How about in public health emergencies? I think we have witnessed how COVID devastated and also disrupted the healthcare system that exists and the limited care that we are able to provide our patients. And that can significantly increase oxygen need by itself. Also, different conditions like conflict can destroy health facilities and oxygen infrastructure, and also in situations like natural disasters restrict access to care. So, in 2029, at the time of COVID, 52 million people with COVID-19 needed oxygen. So when you look at the graph right there, you're able to see the trend. Is there an increased need? There is a modest increase in increased need of oxygen. And due to primarily acute medical and surgical conditions, when you compare it to 2010 until now, it's about 10% increment in need. We'd like to emphasize here the importance of prevention, like provision of vaccination, healthy diets, drug and alcohol use, malnutrition, pollution, accidents, and injuries. prevention is the key to minimizing the need of oxygen. So now I've given you the numbers of oxygen need. Among those who need oxygen, who actually get it? So we'll be talking about oxygen coverage. Less than 1 in 3 people who need oxygen for acute medical surgical conditions, they receive it. You can imagine this is 70% coverage gap that's seen in oxygen coverage. When you compare it to HIV, AIDS, and tuberculosis, where the coverage gap is mainly less than 25%, it's 70%. And oxygen, as you know, it's the breath of life. Do you think that it is fair that oxygen gets this degree of coverage gap and also we have no objection to HIV care or tuberculosis care, but oxygen is a breath of life, and yet the coverage is significantly very, very low. Okay, so less than 1 in 3 people have mentioned receive it, and we have divided to see which conditions, acute medical and surgical conditions, and we can see that the numbers along with it. Long-term oxygen therapy is not included because of lack of data, and I would like to emphasize here that data has been some of the significant limitation in providing the numbers in the calculation process. So for sub-Saharan Africa, there are different levels of coverage gaps. In the first place, patient may have difficulty in reaching care, which we call contact gap, and that is significant. But for majority of sub-Saharan Africa, among those patients who reach to health facilities, then it's actually readiness gap, where the facilities then either have the oxygen infrastructure or the manpower that are able to provide those cares. And among those, as you can see from here, among those that are ready to provide oxygen care, there are those that just don't get it for whatever reason. It's either a knowledge gap of healthcare providers or any other situation that they don't provide oxygen for them, even though it's present. And then among those who actually get oxygen, then there is a quality issue to the quality of oxygen they receive, or the standard of oxygen that's available within that institution. So for surgical conditions, it's mostly, as you can see, the gap is mostly contact gap. So there was a significant number I've shown you. Contact gap, accessing surgical care by itself, a significant gap that we were able to see through the Lancet Commission report on global surgery. So that brought the major gap in oxygen coverage as well, because without oxygen, surgery cannot be undertaken. All right, so there are regional differences, which you can clearly see that South Asia, East Asia, and the Pacific, and Sub-Saharan Africa are one of the highest where we see the gaps in oxygen coverage. And we're able to narrate that for acute medical conditions, but there's no breakdown for surgical and chronic conditions due to lack of data. See, there's a lot of recommendations that I will put forward later on, but one of this is for the quality of data that needs to come out regarding oxygen. All right, so when you compare pulse oximeter and oxygen availability among the type of health facility, primary versus general hospital or tertiary level hospital, there's a significant difference. Now we note that about only 10 to 12% of primary health facilities are able to provide pulse oximeter and oxygen for their patients. And this gap is pronounced, and we were able to witness that through this Lancet Commission work. And when you compare it to rural versus urban, it's 3 times lower. And when you compare it to public versus private, it's significantly lower in the public sector, about 3 times lower. All right, so when you compare which facility, within facility, like we were able to see that pediatric wards have a significant also oxygen coverage gap, and emergency, it's available in about 35 to 40% of pediatric wards, and you can see in surgical wards, majority already have it, but accessing the surgery itself is the issue that I've mentioned earlier. So we also wanted to assess what patients think. Does that affect oxygen gaps? Does that affect oxygen delivery? So fears of oxygen, as you know, most patients, by the time they require oxygen, they are really critical. So most patients may assume, if I get oxygen, then I'm more likely to die. So we believe that it can delay health-seeking behavior. But also, on the same side, seeing oxygen bringing significant change can also improve attitude. So there's a lot of advocacy that needs to be worked on. What about the costs for patients? So patients may assume it would cost me more, so I'd rather not get it. So the costs are significant. And at the time of COVID-19, there were so many patients that weren't able to afford the oxygen they needed, and it was completely out, and the prices were significantly high. And for oxygen therapy, as you know, most of it is provided in inpatient, and they may not have the money for that. So with that, I'll invite Freddie to walk you through oxygen costs. Thank you.
Thank you very much, Radiat, indeed. So the presentation continues. We know what the problem is. We know how much we've done in terms of addressing the problem. I'm sure many of us are asking ourselves, what is the cost? How much does it cost? In the room, we have donors. We have those who support our governments. We also have those who support the patients through out-of-pocket. And the key message from the report is that there should be no question as to whether investment in oxygen system strengthening is value for money. Rather, the focus should be on how much funding is needed and how this money should be most effectively spent. The next set of slides will basically expound on that. So the report, the Commission estimated how much we need to cover the current gap, and from the data that was available, globally, we need about 6.8 billion every year to close the gaps that Radiat has taken time to take us through, of which the big three are in Sub-Saharan Africa, South Asia, and Asia Pacific. So that gives us about 34 billion over the next 5 years. And we illustrate that with a quote from a patient in Sierra Leone. A COVID patient used about 4 cylinders per day, as we ran out quickly and asked the health ministry to send more, but they did not have enough money. In terms of that cost, you see most of it is required in South Asia. Sub-Saharan Africa, where Uganda is, we need just about 1.7 billion, which, again, is not so huge of a figure. And again, the graph shows us that most of the cost is actually due to 92% of the gap is due to acute medical oxygen needs. In terms of emergencies, we basically demonstrate what is needed for routine care, but also what will happen in case we have an emergency similar to COVID-19. So COVID, if we were to experience another event similar to COVID-19, an additional 6.8 billion is needed. So in a way, when we design our systems, we need to design for routine care, but also we need to pre-plan for surge. We need to be able to increase demand in case we face an event like COVID-19. Also, long-term therapy showed that, particularly in high-income countries, had a substantial need and therefore cost. The cost to meet the long-term oxygen therapy was about 3 to 10 billion a year, and again, based on the limited data, that's why we have that wide range. And of course, most of it was attributable to high-income countries where a provision of long-term oxygen as a service is more well-developed and there is a bit more data. Limited power supply will also exacerbate inequities in home oxygen access. We know that a lot of the oxygen delivery service devices require electricity and so on. So in a way, in preparation for our aging population, for the increasing need in long-term oxygen therapy, we need to think about powering our homes as well as part of the solution to actually increasing access to medical oxygen. Again, as we started, it's not how much it costs, or when the Commission considered and compared the cost effectiveness of oxygen therapy against other known interventions. It was found that it was actually similar to vaccination, for instance. It was estimated that the investment in oxygen services was about 44 to 59 per daily averted, which is very similar to the same outcomes we see with vaccination. Each dollar invested could deliver estimated returns of about $21, and additional funding can cost approximately $160 per disability-adjusted life year averted, and as little as 23 in countries with higher burdens. And this is based on the report that was commissioned by the Global Oxygen Alliance. So in a way, investing in oxygen is cost-effective and is comparable to other well-known interventions that have given us a lot of gains. Vaccination. When it comes to oxygen with solar, a bit more expensive in areas where the infrastructure is still low, but still as cost-effective as vaccination. And then where there's no solar, where there's already developed power delivery, the cost is lower. But again, over time, solar could rival. So the question then is, what are the solutions? We've looked at the cost. We need about $7 billion per year as a globe. For sub-Saharan Africa, about $2 billion. But what will this $2 billion be spent on? So the Commission addressed broadly 5 areas based on the data that was available in terms of gaps. One area was pulse oximetry. The other is strengthening oxygen systems. The other, managing national oxygen systems, strengthening markets, because it was realized that actually oxygen, to provide medical oxygen to a patient, there are many layers, there are many stakeholders that I need to interact with within the health facility, within the ministry, within the national government, but also within the globe, the oxygen market. So the first solution is ensuring that measuring hypoxemia, taking oxygen saturation is a vital sign. The way we triage using fever, using blood pressure, and so on and so forth. So pulse oximetry is a gateway to safe and appropriate use of medical oxygen. As we saw, coverage of pulse oximetry was lowest in lower level health facilities, where people with uncompleted illnesses start seeking care. So going forward, ensuring that those facilities are prioritized in terms of having pulse oximetry is important. Implementation of pulse oximetry is feasible. Again, studies have showed that. Introduction needs to consider wide service provision capacities, but also they need to ensure that there's a functional referral system. Because what the pulse oximeter will tell you is how sick a patient is, and sometimes they'll need more specialized care. So there should be a referral service, and I'm sure many of the panelists will talk about this in the panel discussion. Pulse oximetry is also key to maximizing the cost efficiency of oxygen systems, and this was based on work that was done by the team from Malawi, based on their models that looks at the national health system. Integrating pulse oximetry as one of the key services showed that investments made in oxygen delivery were more cost effective, because then you're able to separate those who actually need oxygen from those who don't. The second solution is about resilient oxygen systems. Again, systems. Oxygen as a product is quite simple and straightforward, but delivering it routinely, sustainably to the patient requires a system. And these systems should fit the context. The context in a primary health facility are different from the context from a tertiary hospital. The context in ICU is different from a context from a general ward, and that should be taken into account. The other lesson that probably Uganda contributed to, and many other contexts, that setting up oxygen systems should be mixed source. So you cannot, for instance, select to have only liquid oxygen. You need to have the different solutions serving and providing oxygen to the different contexts. So the PSA plants, oxygen concentrators, cylinders, again, each of them you leverage on its advantages and minimize the challenges of each. And then, of course, you need backup oxygen sources, particularly in settings where systems are just still setting up. We need to have affordable and uninterrupted clean power. You read the details in the report. We have a number of copies of the book that we encourage you to take with you. In terms of building these resilient systems, one of the things about costs, particularly for oxygen sources, was also explored. And it was discovered that most of the costs, so the graph on the left of this, on the right, your right of the screen, shows us the breakdown. You see that for PSA plants, at the top, cylinders, midway, pulse oximetry, you have capital costs for PSA plants being quite high, but then you have the gray area, which represents energy. So planning for cheaper oxygen sources is very critical when setting up these systems. Whereas for cylinders, there is basically no need for power. And this is why choosing and making sure that you're mixing the different sources is critical. Distribution costs, of course, become important in cylinders. Low-cost pulse oximeters can have higher total cost of ownership if they require frequent replacement. So the report also goes into what kind of pulse oximeters do we need. We need high-performing, durable pulse oximeters that are trusted by the people who use them. Moving on to still on the resilient systems, part of the system is ensuring that you have the workforce. The skill and density of the people needed to operate the different parts of the system is critical. And one of the things the Commission emphasizes is that biomedical engineers are health workers, and they need to be deployed in adequate numbers in areas within the health system where they are part of that medical oxygen system, but also support other equipment that we require to deliver healthcare. They are also a source of innovation, so they're not just contributing to preserving to service delivery, but they are also innovating to solve some of the challenges. The other solution is about coordinated management, which, as Uganda, have advanced coordination at national level, coordination within the district, coordination within the facility, because delivering oxygen requires several components working together, different skill sets are coming together to ensure that that patient who needs oxygen, gasping or air, gets it in the amount they need it and they're weaned off as soon as they don't need it. Of course, the coordination also goes on to global level. And again, there are a number of recommendations to the funders, to the UN agencies that basically push some of this agenda. And then the regulation and the markets. Oxygen, for some people, is a product that needs to be sold. So ensuring that, again, when we are setting up the oxygen systems, you take cognizance of what the market is. For instance, ensuring that there are no monopolies, ensuring that the contracts you have with these companies are long-term, they take into account maintenance, spare parts, and then they also ensure that the parts that you're using are interoperable, are some of the things that are attached in the report. One of the things that came up is that representation at global level on some of these, particularly the International Standards Organization, is low for low-income countries. You see that most of the membership is from high-income countries, the US, deep pink, and then South America, then the US, and then Europe, and almost nothing for Africa except South Africa. And one of the recommendations is that this representation actually needs to take into account where the need is, as we saw from the earlier slides, and so on. The other solution is that we need data. A lot of the work that we presented depended on data, but also identified data gaps. So data in terms of oxygen solutions, but also generally systems, is also a solution. Accurate and timely data is essential, and the Commission report also provides some ways in which this data can be generated by going in through some of the metrics at facility level, and it recommends 10 oxygen coverage indicators that we invite you to look at once you get a copy of your report, clearly well-defined. It also provides ways in which a Ministry of Health can be able to monitor progress. And this scorecard, which a number of colleagues have interacted with because it was tested in Uganda, looks at how ministry can monitor progress against the World Health Resolution recommendations that Uganda sponsored and eventually was adopted at the World Health Assembly. So it looks at a number of components in the architecture, whether oxygen is available, affordable, whether it's been adopted, the oxygen and oxygen services. It looks at the coverage indicators, and all those feed into what we call the Atmos scorecard, which has been adopted by the WHO and in not a very, in the medium, short to medium term, Ministry of Health will be requested to actually report back and complete this tool to demonstrate progress against some of the recommendations. And these metrics need to cover the different aspects of oxygen, as already illustrated. The total picture from where care is sought, so care seeking, detection, oxygen provision, delivery, eventually discharging the patients, but also the whole ecosystem of producing quality assured oxygen in a reliable way. So there are also a number of areas that required innovation, and the report summarizes about 20 priority areas where we, the oxygen fraternity, need to innovate and think harder. And these basically pulse oximetry, oxygen supply systems, how we can coordinate better, summarized in that table, but I invite you to look at the details in the report. Lastly, the report, the Commission also identified areas that we need to continue researching. Big opportunities, addressing the current oxygen gaps. And on the slide, we divide them into three. So there are areas that require additional research. We still, despite the fact that we have estimates of the burden at global level, we still need to adapt that to our levels in our health facilities. What's the hypoxemia burden? How is it distributed? And what are some of the variables that bring in inequity and so on and so forth? Long-term oxygen therapy in low-income countries is basically still an open book, not much information. How to address oxygen gaps, cost drivers, and so on and so forth. The other big area where research questions remain is the delivery of oxygen. And this requires continuous piloting, engineering, and testing, and ensuring that lessons learned are carried on to get a better product. And then development as well, in terms of estimating the needs, in terms of collecting the data required, in terms of providing oxygen in humanitarian contexts, in terms of the AI era, what's the role of AI in trying to address this? So with that, we'll move on to the last set of slides that focus on recommendations, again delivered by the Commissioner. Thank you.
This is going to be very quick, so don't worry. So the Commissioner has put together 52 recommendations for different levels of, like Dr. Freddy Kututu mentioned, it's an oxygen system that's required for delivery, right? So for governments, industry, for donors, for professionals, for civil societies, global health, for different standardization organizations, for academics, we've been mentioning data. So we've put together 52 recommendations. I'm not gonna go through each of them, but I highly recommend you to go through the Lancet Commission report. Just to give you an example, only for government, there is recommendation to develop national medical oxygen plans to increase domestic spending, to negotiate affordable and reliable oxygen contracts with industry, and also integrate oxygen indicators in the health performance data. We have put together oxygen indicators in the Lancet report, which you can access. So very similar to that for each stakeholder in the oxygen delivery. We've put together 52 recommendations. So with this, I leave you. that it is with this commission that the recommendations we put forward, national medical oxygen systems can be at the forefront of efforts to create the future we want, because oxygen is a breath of life. And without oxygen, there is no life. Thank you.
Please join me to give a more befitting applaud for the presentation. Thank you very much. We are going to open up for questions, but we thought it wise to make a bigger panel so that we can address many questions from as many perspectives as possible. And in that regard, the panel is going to be moderated with no other than Dr. Fred Kitutu. But allow me to give some recognition and acknowledgement. This work would not have been possible without the role played by the Lancet. And there we have Zoe Mullen, who is the executive editor at the Lancet, but also our colleague, this Greenhalgh, who sits with the All Breath Count in New York, and this was a big chaperone to try to make this report possible in terms of ensuring that executive committee meetings and all events take place. We also had a secretariat made up of Karolinska Institute, and there we have two colleagues, Professor Peterson Swatting and Professor Karen King. At the Murdoch Pediatric Institute in Melbourne, Australia, we had Professor Hamish Graham. At ICDDRB, this is the Center for Diarrheal Diseases in Bangladesh, we had Professor Shams El Eterim, and at Makerere University, we had, as you saw, Fred Kitutu and myself. So this was, but also these were joined by 20 other commissioners in the room. We have myself and as commissioners. We had 40 advisors and 100 collaborators. The idea was to ensure that the generation of this report does not leave any stakeholder out, negotiate all feasible actions from as many perspectives as possible. We had a session here before on alcohol, and I think the message is sometimes when you need to make binding decisions, you need to ensure that those players that are going to be part or in any way take a role should be in the process. So that's why we had such a big. So allow me now to, Fred, can you help me invite all of the panelists? My phone has blacked out on the power, so I can't read. Thank you.
Thank you very much. I think a round of applause for Professor. He's the first panelist, Commissioner, Professor Fred Sengova, over health policy and planning at the university. We have the representative of Dr. Charles Solaro. Dr. Charles Solaro, the Director General of Health Services at the Ministry of Health. Let's have Engineer Tadeo Byabagambi, who is Assistant Commissioner. I think he will be wearing several shoes. And then we have. Yes, thank you very much. So the representative of the Director General, our colleague, Dr. Dan Chavainze. Sorry, I think I missed you as you're just coming in. We invite you to join the panel next to Professor Fred Sengova, the Commissioner. We have representatives of donors and UN agencies, UNICEF, Dr. Stefan Mark Lawson. Please welcome you to the panel. We have colleagues from academia who contributed over the period of 2 years, starting with the most recent PhD graduate. You know, those of us who have been through the process, Arthur is now at the highest level of knowledge. From here, it's downstream all the way. So let's welcome Dr. Arthur Kwizera, Associate Professor of Anesthesia and Critical Care at Makerere University, and then let's welcome Dr. Robert Sechitoleko, the Head of Department of the Pioneer Program in Biomedical Engineering in Uganda and probably the region. Yes, of course, Commissioner Rediet, please join the panel just in case there are any hard questions about the report. So we have copies that we shall give out. So as a way of starting out, we'll have time for you to ask questions, but as a way we want to get to know a few things from the members of the panel. We'll start with Commissioner Prof. Sengova laying the ground, linking. Yeah, we have this report of about 20,000 words, many recommendations. We also know that this report was born out of the COVID experience as a globe, and there was a lot of traction, momentum to address global health security. That's the way we framed COVID-19 and other related things. How do you think, what do you think should happen to maintain the momentum? COVID-19 seems like history to many people, and so, you know, out of mind, out of sight. How do we maintain this momentum?
Well, thank you, Freddie, and colleague, thanks for bearing and being with us, coming to bear witness. As I said, one of the goals is to give this report more legs, more voice, and impact. And since the launch of this report back in March, we've had various chapter launches in various continents and countries. Again, it's to bring, first of all, this report to the audience and the practitioners and academia and all the ecosystem actors. As you saw, oxygen touches many areas. We believe that first step is real awareness of what needs to be done. First of all, also appreciating that we need to work together, but also to figure out where we need to work in unison. I was very happy to hear the PS presentation up in the afternoon, this early afternoon, about how do we work as one? And in particular, how do we ensure that we come together to achieve that common purpose? And oxygen is one of those things that we all know is important. But somehow, when it is needed, you discover there are a lot of gaps in the facility. When I used to be a doctor at some point when I was young, now I grew out of clinical care. But just putting the person on a cylinder, you realize sometimes, what is that thing called? A spanner. To turn on the cylinder can disappear, and you spend 2 hours looking for a spanner. And you can't really open that cylinder. Some health workers, you can't get there are about 7 tasks to actually put on a cylinder. There is the moving it, but there is trying to ensure that you've put the humidifier there, there is the tubes, there is the flow. There are so many connections. So even that alone can actually make care to be missed and the person to actually get complication, if not pass away. So even those skills, we can talk of training. We have many academicians here, but you can go all the way to research. We have many gaps you've had, but also investment-wise. I'm happy to say that Uganda is being mentioned in the report and many other places as one of the lead, because we've had a national implementation plan for oxygen for some time, since 2018, even before COVID was here. Many other countries are just waking up to this. I think last year around this time, we had about 34 countries that had a national plan for oxygen, literally in our region. So meaning that there is a lot of catching up. But we also want to see that this catching up is not just government, is not just service provider, but how do we ensure that the solutions work for us? How do we ensure that we are all investing in a coherent way? Many of you will point to some PSA that we implemented during COVID that may actually be shut down. I've gone around some of the hospitals, you find it worked for some time, but the power was too much, the cost was too much, the skills was not there. So we've closed. We went to one, and it took us almost 3 hours before somebody knew where the key is to the PSA. You remember?
Yes, yes.
So there is still these issues that we've invested, but somehow the investment is not in play. And so these are the challenges that we would like to keep awakening. And this kind of launch is to get all of us to see how do we ensure that we play our rightful role and somehow get to the last mile. When the oxygen is needed to that patient who needs it, you saw within 5 minutes, if you can't really get the connection, you can actually lose a life. And that is the challenge when it comes to oxygen, especially in intensive care. And we would like to see that this area of oxygen becomes more like we do utilities. All of you, when we say utilities, we think of water, you have to pay for it. Electricity, you have to pay for it. Oxygen also should be more like that. But also when it comes to care, there should be those things like we take a pulse when we are not sure. We should have a way to measure, is the oxygen reaching the tissue in a way that we can measure. That's the pulse oximetry. I'll stop there.
Thank you very much, Prof. I think you've pivoted towards the role of government. And before I invite Dr. Dan Chavainze to come in, I want to recognize the role Minister of Health played in this commission report. When you read the report, you'll see many examples of what Uganda has actually been implementing and so on. It's also now time for me to invite the youngest member of the panel, who was part of that journey, Mr. Blasio Kunihira. Please join the panelists and contribute. So, Dr. Dan Chavainze, from what ministry has done and from what the commission report summarizes, what are some of the key priorities, current priorities that the ministry is focusing on to bring some of these messages from the report that started the commission, that started here, as Professor Sengova mentioned, and is now coming back home in the full report? What are those key priorities that the ministry is working on, and how do you think that the audience here and those that are watching us should support them? Thank you.
Thank you, Dr. Frederick Chitutu. The report has highlighted many things, but when you ask government priorities, what government does best is to set the policy framework in which everybody can work. So we've already done the national planning. We have the 2023-2028 plan. When you have a plan, it's not just have a plan, but to make sure you walk the talk. So in top of having the plan, the infrastructure, my colleagues will explain what the infrastructure has and how it's been rolled out. In fact, most of it is already described. So our priority, where you don't want to go to a site which has been closed down, is to make sure we enhance what we've developed, maintain, train the people, recruit, retain, and actually sustain that whole process. It's not going to be a one-off. So the whole chain of having, the ecosystem of having oxygen as an essential supply in all hospitals is the priority for government. And my colleagues will be able to speak to much detail. If you want, I would have given everything, but then what will they say? Because
thank you very much, Dr. Chavainze. We shall come back to that, but let's bring in the colleagues you've referred to. Lawson, Dr. Lawson Stefan from UNICEF. From the experience of supporting this complex area in Uganda and in many other countries, what are some of the lessons you've learned that you can share with all the other actors still in the space in terms of sustaining a lot of the investments that are already in place and accelerating the progress, accelerating the closing of the gaps to ensure that patients who need oxygen today receive it in the way that is desired?
Yeah, thank you, Chair, and thank you, fellow panelists. I think the first thing is to recognize the incredible journey that that Uganda has gone on and the commendable progress that it's made in terms of its medical oxygen ecosystem. And UNICEF, as a partner of the Ministry of Health, has had the privilege of supporting the Uganda in this journey. There, our recommendations, I think, are well aligned with the Commission's report and also aligned with the experiences that we've had in supporting the ministry here in Uganda. Just as a couple of examples of the work that we've done, my colleague mentioned the National Medical Oxygen Scale-Up Plan. We supported that initiative. Since COVID-19, we've supported the Ministry of Health in procuring and installing a large quantity of infrastructure, be that PSA plants or oxygen concentrators or medical gas piping in hospitals. We've also been working on innovative public-private partnership solutions for oxygen, oxygen as a service, where we have a pilot in 35 health facilities deploying 60 resilient oxygen concentrators to bridge the equity gap. And then improved sort of support around patient care, and current work is around the investment case. So based on that experience, there are 6 recommendations to help accelerate and sustain this momentum. The first recommendation is really around institutionalizing the total cost of ownership. We need to move away from thinking just about the initial capital investment of the equipment, of the oxygen equipment that we put here in country, but really start thinking about planning and budgeting for the full life cycle costs of oxygen systems, which include power, maintenance, spare parts, distribution. We've begun to do that with maintenance contracts for the PSA plants, but something that we need to continue to work on. I think secondly is around data for oxygen. Having a robust national data system to track our oxygen consumption, our equipment functionality, our patient outcomes is really essential, because that data, real-time data, will really help us in our proactive maintenance, forecasting, and distribution of oxygen around the country. I think then we've also mentioned about a diversified oxygen supply. It's not just about PSA plants. They may be the cornerstone, but we need to think about other alternatives, liquid oxygen for high-demand facilities, resilient concentrators for lower-level and remote facilities, so that we create that diversified and robust oxygen infrastructure. I think then really around financing, sustainable financing, is, how do we ensure that we are putting aside enough money for the sustainable operation of the oxygen ecosystem here in Uganda. And so thinking about the work that we're doing on the investment case, and we'll need to continue to accelerate that work and use it to advocate for ring-fenced budget lines for oxygen in the future.
Yeah, Stefan, before you continue, I wanted the colleagues from biomedical engineering to come in on your previous point of diversified sources. And we first hear from Dr. Robert Sechtoreko from academia. He's mentioned how it's important to have the mixed oxygen sources for the different contexts, leveraging on their strengths and minimizing exposure of their limitations. What are some of the promising local innovations on the horizon in this space, and how do you think Uganda can take advantage of them?
Thank you, Chair. Thank you, colleagues. I think to start with, I would say that I mean the academic institutions, we are innovating for oxygen well before COVID. We are looking for technologies towards maybe diagnosis of pneumonia and also monitoring progress towards treatment and so forth. We always knew there was an issue with the current form of the oxygen concentrators. They are designed not to work in dusty environments and so forth. So there were always people trying to look into improving that. Even distributing oxygen to patients, we went to many wards where we'd see so many connectors connecting without really thinking about the splitting and filtering per patient. So there were teams working on that already. Now COVID-19 kicks in, and it gets everyone to remember that actually we need to pump up this innovation. And so we started even looking more. And the great thing is now the entire world, whereas they were thinking of innovations useful for their own countries, they were more focusing on innovations that would come to us. If the United States is suffering with access to oxygen generation systems, oxygen concentrators and the plants, what about Uganda, for example? And so we then started seeing an influx of innovations that people were working on across the world coming to us and trying to improve them, trying to make them contextually appropriate. As you rightly said, an oxygen plant will not work in each of the low-level health facility, but for example, an oxygen concentrator, very nicely trusted if it's maintained well, and there are teams working on improving this oxygen concentrator. How can it work in our dusty environment? And even how can we reclean the material that absorbs nitrogen from the air to make concentrated? Before COVID-19, we didn't know that we could actually reclean that material and put back in the canisters. Now we have teams that can do that and have them readily available, so we don't have to spend lots of money doing that. Whereas there are these really nice and fascinating innovations, I also want to also highlight within the report, we write about biomedical engineers as crucial part of the healthcare provision team. And we as biomedical engineers, our main concern is about medical devices. Just like a doctor would care about a patient, we care that a medical device, whether it's coming through local innovation or through procurement from international partners, how can it give us the best life possible for treating patients? And also, I probably want to highlight that all the innovations that we have, for example, at Makerere, we have quite a lot of innovations around medical devices. Our colleagues have even set up what they call a hypoxia lab, and is for testing these devices that are used for respiratory care. Case in point is pulse oximeters. Before COVID-19, we did not realize that they were not so good on dark tone skin. Now we are working to improve that to make sure that they are actually calibrated to dark tone skin. With all these innovations, there's also a need for seeing how can we translate them to being used. This is where our regulators and our policymakers can help to maybe help to translate. Translation is another beast. It's not engineering, but it is another beast that involves so many players in different corners. And for me, I think I would say, let's translate this. One device I can maybe highlight is colleagues from University of Leeds developed a CPAP device, which is very, very easy to use, and they developed it in response to COVID-19. It was, they did a clinical trial in Mengo, and now it's actually ready to start going out to be manufactured. And we are working with them now to see that it's locally developed here, and we can start selling them. We know very well that there are so many unknowns, but at least we are trying to navigate that journey to see that our local innovations, as well as the innovations from our partners internationally, can be utilized, and we can use them to create jobs, but also answer to the need in healthcare provision.
Yes, thank you very much, Dr. Sechitoleko. And I know Engineer Byamagambi is itching to come in, but before he does, let's hear some of the lessons from the field from Blasio. who has been, again, as part of CHAI, in the middle of strengthening the systems we've talked about in many facilities in Uganda, but also across Africa and Asia. What for you, what does this report mean, and what have you learned that we need to take forward?
Thank you very much, session chair, panelists, and the audience. As Clinton Health Access Initiative, one of the partners that works very closely with the government and other partners, especially in the oxygen space, we have learned that government leadership ensures sustainability. And that is one of the lessons that we have learned with the work that we have been implementing in Uganda. The other is integration builds efficiency. We don't have to reinvent the wheel. If there are already existing systems, we can work with those existing systems and ensure that medical oxygen is integrated into those systems and work with the government to strengthen where there are areas of, that need strengthening. Then data visibility also drives accountability. That's one of the lessons. Accountability, but also monitoring of implementation. Finally, partnerships multiply impact. Where you many stakeholders in the space, it is very important to all of you work together to have a unified response. That's it.
Thank you very much. I know the youngest member of the panel has a lot to say, but you know, being Gen Z, time is summarize the key messages. Let's now hear from Dr. Arthur, who summarized his work of 5 years in 25 minutes a couple of days ago. I don't know, I'm sure you have a key message, particularly the Commission report focuses on broadly. Oxygen focuses on basic oxygen care, but there are also areas where it talks about critical care. And I know your work was in the ICUs, focusing on very sick patients and so on. So what do we draw from the report from your work in improving access to medical oxygen for those kind of patients based on the work you did in Uganda?
Thank you, Chair, panelists, and audience. Yeah, I think the focus of my work has been really acute organ dysfunction. Basically, any organ that fails. Professor Ngoba referred to many organs, brains, and so on. So we decided to tackle the lungs first because, as everybody knows, the two most important elements on Earth are water and oxygen. And so we decided, so okay, fine. Luckily enough, the work, when I started my PhD work, I started working with the ministry and CHAI in the National Scale-Up Plan. So went to 81 hospitals around the country, so did baseline evaluations and so on. We just finished a multi-center clinical trial, and one of the things we discovered along the way is that we were also working with the ministry to build intensive care units at regional referral hospitals, was that the ICU capacity is never going to be enough. Even high-income countries suffer with that. And of course, we made sure that oxygen became the most central tenet, and COVID taught us that almost every disease that has been discussed in this conference, in extremis, the patient needs oxygen. So we then said, okay, let's do this study in non-ICU facilities, get medical officers and nurses, because I'm an intensivist with 20 years experience and so on. All the training I know many people will never get. And we said, okay, can we not task shift, but task share this? And the trial was looking at, one, the feasibility, obviously, of these innovative devices, and two, if medical officers or lower level health cadres at district health centers can apply the therapy that we typically apply in the ICUs and by highly specialized people. And the results, well, are out, but we showed that one, whether it's high flow, whether it's CPAP therapy, the medical officers and the junior health workers can actually do that. And what that does is that we hosted the Ministry of Health, the Oxygen Task Force, and we presented these findings to them. And now, we now know that as the Commission report focuses on oxygen security, we now have evidence that even at the lowest levels outside of the ICU, a high level of advanced oxygen therapy can be provided by health workers. Thank you.
Thank you very much. And Arthur will share with us the link to his report, or he will provide with the organizers to share. It was an amazing defense 3 days ago, and I thought he would be on honeymoon or something, but we are happy that he found time to join us. I don't know, Radiate, do you want to add to that before I bring in Engineer Byavagambi, critical care and oxygen, or you want to wait for questions from the audience?
I don't have much to say after all that I have mentioned regarding the cost coverage and recommendations. But I just, I'm an anesthesiologist, so as an anesthesiologist, I work in the perioperative system. So much of the things that I notice as clinician as well as a public health expert is the wastage that happens when it comes to oxygen. Not all patients require 100% oxygen during surgery in the perioperative area, but due to lack of knowledge, we waste so much energy, so much oxygen, which could potentially go to those who actually need it. So in the perioperative era, not only those that don't access surgery is a gap, but also we can talk about inefficiencies that we did not account for in estimating some of the needs or coverage gaps. Thank you.
Thank you very much, Radiate. And I have two questions for the last panelists today, Indian Byavagambi, before we open up to the audience. The first one is about the biomedical engineering workforce. The second one, we reference page 50 of the report, and I request help me pass on page 50. I'll come to it. So about the engineering, the biomedical engineering workforce, the report, of course, recognizes that they are essential health workers. They should be part of planning and deployment at all levels where we have medical equipment supporting delivery of care. What are some of the ways in which we can improve the training? We heard from Dr. Sechitoleko, but you as a person who employs his products, our products as a university, what are the opportunities to improve so that by the time they come to you, they're ready-made for these challenges? I think you can answer that before I go to the second one.
Thank you very much, the panelists, and allow me, before I talk, recognize my boss, Director General, who is here with me, and also add the voice on what he has said as per investment in oxygen by Ministry of Health. As a country, following the strategic plan, we have gone further to do decentralization of oxygen production. And as we talk now, in 2017, we had to decentralize oxygen production by installing and commissioning oxygen plants at regional referral. And the regional referral in 2017 were 14 regional referral, where we had to ensure that all regional referral get PSA plant. Why did we do that? We did it because at that time, the company or the body that was in charge of distribution of oxygen was NMS, and the delivery of oxygen from headquarters to this regional referral was taking time. And so we had to decentralize oxygen by installing oxygen plants in 14 regional FARO. Recently, we went ahead to further provide high-capacity oxygen plants, and the total number of oxygen plants that we bought recently were 22 PSA plants that we have been able to install in regional referral and also national referral. Furthermore, we have now embarked on further decentralizing oxygen production, and as we talk, we have done a pilot study at Kaolo and Iganga through the support of UNICEF to see or to prove whether we can further distribute oxygen at general hospitals, and it has been proved that indeed it can work because infrastructure is in place. Please, let's clap for UNICEF for that support. Again, we have, ministry has strategically invested in another model, which is called cryogenic system, where we have put a 60,000 liter tank at NMS headquarters, and also a 16,000 liter tank at Mulago Hospital, to ensure that in case the PSA plants all over the country are under service and maintenance, these two heavy resilient tanks, which are cryogenic, are able to deliver oxygen across the whole country. And we have again gone further, following what we call infrastructure plan, and we have launched another good model, which is called Oxygen as a Service, which has a mini system for production of oxygen. And as we talk now, it has been rolled. The installation is ongoing at Health Center 4 to ensure that there is no any patient that will lack oxygen. And this model has been heavily supported by UNICEF to ensure that we have mean production of oxygen at Health Center 4. And as we talk, our target is to ensure that about 35 Health Center 4 receive this mean production system of oxygen. And again, we should thank UNICEF for being pioneering in this oxygen.
Engineer
Lastly,
Byabagamba, you've actually set a ground for my question based on the report, which I want now to bring. Obviously, I think these are huge investments, and these investments in equipment are necessary, but what the report shows us, but not sufficient. Now, from the report, about $4 million USD in a period of between 2 years, 2020 and 2023, had been spent on equipment. But what was realized that about 100 million of that was on ventilators, another 76 million was on PSA plants, 81 million on concentrators, 38 million on pulse oximeters. Less than 1% was spent on training, and no, on training, operational support, and power solutions. So the question is, with all these investments, and then of course the report goes on to show that a lot of this investment actually remained, they use the term equipment graveyard, or the efficiency of that investment was not because of lack of training, operational support, maintenance, which as Stefan mentioned. And I think you are coming to that. What do you think are the solutions going forward to ensure that these investments do not just focus on bringing in the equipment, but rather on the 20-year life plan for the PSA plant. And other members will come in when we open. So any comments to ensure that this equipment actually remain functional, efficient, and used to the maximum?
Okay, thank you very much, panelists. And I wish to inform you that as Minister of Health, we have launched first of policy guideline, which is called the National Medical Equipment Policy Guideline, that focuses on developing capacity of biomedical engineers and technicians, that also focuses on standardization and harmonization of this equipment, and also focuses on placement of these heavy investments. And as we talk now, in the short term, we have already started implementing this policy guideline to ensure that our gains, or the health infrastructure gains, are protected. And one model that we have engineered on through between academia and industry is through what we call CPD, that is continuous professional development, where we are working with academia to ensure that we develop modules that will enhance the capacity of in-house biomedical engineers and technicians, and also about to graduate biomedical engineers and technicians.
Thank you, Engineer
Mewagambi.
Let's now take some questions, and then we have been given a hard stop for the hotel. But yeah, you see that a lot of work has gone into implementing some of the recommendations. So any questions before
Panelists, this is a chance for audience to know the number of which the ministry has invested in, and it is our time that they should also know that one of the sustainability model, we have come up with 16 regional biomedical engineering workshops, and they are also in place to ensure that this sustainability is achieved. And also, lastly, we have expanded the human resource capacity structure from national referral up to Health Center 4 to ensure that these cadres of biomedical engineers and technicians are recruited. And as we talk now, out of 16 regional referrals that we have, the ministry has been able to recruit for all 14 regional referrals. They all have biomedical engineers and technicians. The remaining 2 regional referrals are targeted this financial year to ensure that we consume these health care workers who are biomedical engineers and technicians that are coming from academia. Thank you very much.
Yeah. I think that deserves a clap. Thank you very much for that summary. So we have a few minutes for burning questions from the audience. Please, straight, don't give us a preamble. Just, if possible, identify the panelists you want to respond to, and then straight to the point. So let's start with the lady. Yes, thank you.
Thank you very much. That was a wonderful presentation. I want to appreciate the panel. My question goes to you, Dr. Chitutu. You did a great work in making the presentation and explaining the gaps we have. Now that we are discussing integration and the desire to go to communities, we've heard very well that there are lots of road traffic accidents. In line with the fact that we need to save lives, especially the culprits of RTAs, I've not heard very well how we've equipped ambulances from the ministry and what responses we've put in place to ensure that even the ambulances that come to these sites are well equipped with oxygen and pulse oximeters. Thank you.
Thank you very much. Let's take a couple more questions.
Yes,
so
I have a question. As Dr. Reddy had mentioned, the aspect of inefficiencies. Because I guess the law of economics, you can either just increase the supply or reduce the demand. And it seems if there are a lot of inefficiencies and maybe even fraud in usage of these oxygens, how do you see technology? It might be counterintuitive to hire in more biomedical engineers, but maybe even replacing AI, of course, sensors, and maybe even robots.
Thank you very much. Good question. Keep it brief and to the point.
Dan Mrams is my name, and my question is on liquid oxygen. And I wanted to find out the progress and the priorities on these alternative sources, especially in the context of Uganda's budget.
Thank you very much. Cryogenic systems.
Thank you very much. I'm Tushabe Teddy. I'm hands-on. I come from Kaba Regional Referral Hospital. I'm an ICU specialist offering the nursing services. So it means most of the patients we encounter with them. This is what is on the ground. Like what the commissioner talked about during COVID-19, cylinders were moving all over. Our country is corrupt. When you go to our facilities, you will find different colors of cylinders: green, red, black. And we come, our hospital is a teaching hospital, so at times it is hard for us when we are teaching the students about the color codes, because like how we know ventilators, where they have invested, there are ventilators which use medical air and oxygen air. So if these cylinders are all over black, green, and you cannot use the standard codes, then we are in problems.
Yes, I think we've got a new question, number of products on the market and interoperability.
Yes, then the second one was on the pulse oximeters. Our beautiful ladies, if I'm heavy, I'm going to deliver, I will go for the gel nails. And it is hard for us, so the team of the biomedicals, they need to give us high-tech pulse oximeters, not these simple ones, because the gel nails, they will not detect the concentration of oxygen.
Yes.
Thank you very much.
Indeed, thank you very much, in line with the recommendation. Yes, the last one.
My name is Fred Bulamba. I'm an anesthesia doctor and also affiliated with the Uganda Hypoxia Lab, which will be testing pulse oximeters so that they are high quality. My question goes to Dr. Reddy, the commissioner. I saw briefly that there are indicators, tracking indicators, but you did not give us a timeline. And I think that even when we don't meet these timelines, for example, surgery 2030 or PPH 2040, even when we don't meet those goals, it helps to direct resources and creates urgency. I would like your comment on that. Thank you.
Yes, thank you very much for being brief, the last one, and we'll hear from the panelists.
Thank you so much for the presentation. I'm Sheila Bagana, a biomedical engineer and oxygen consultant. My question goes to you, Dr. Freddy. You mentioned the money that sub-Saharan Africa needs on a yearly basis to actually maintain a good or sustainable oxygen supply. Did the report explore any interesting financing mechanisms that governments can think about so that they're able to sustain the production and supply of oxygen?
Yes, thank you very much. Let's now take the questions. We'll first hear from the panelists who were identified from my right. So I think, Rediet, you had some questions directed to you.
Yeah, so thank you for all the questions, everyone. Regarding the inefficiencies, what wanted to mention is we did not account for the inefficiencies when we estimated the coverage gap because of lack of data. So it was very difficult to assess. It's just trying to estimate that the coverage gap that we showed is actually very conservative. So when we account for the inefficiencies, it would be even much higher. But I hear you. There should be innovation to minimize what you've mentioned, and there are innovations on the way. And they have been put together in the report as well, so I do encourage you to read that. Thank you.
Thank you very much. And then we had, another, okay, the others were open.
I think there is one more question from Dr. Fred Bulumba regarding the indicators, right? I believe the timeline to report using those indicators and the Atmos scorecard that we have provided, each Minister of Health would be required to report using the scorecard and the indicators. By 2030, there should be reporting, and it would be an annual thing that I believe. Dr. Kitutu, would you comment on that as well?
Yes, I will, but let's hear from the panelists. So there were other questions I'm sure you picked interest in. There was one on ambulances directed to me. As a moderator, I have the liberty to. So I will request Dr. Dan to comment on that. I know that the government has done a bit of work in investing in ambulances. But the report recognizes the different spaces where oxygen is required, and during transfer is one of those. So we talk about the need for referral, the importance of ensuring that patients who are hypoxemic at lower levels are able to be transferred to other facilities in ambulances where they can actually receive oxygen on their way. So there is a bit of that in the report. But Dr. Chavainze will tell us more.
The most interesting question I wanted to answer, I better give start with that. Uganda as a country is not corrupt. Let's set that record clear. There are people in Uganda who have not yet abandoned the practice of being corrupt. We are working with them to improve. But as a country, we are not a corrupt country. So I wanted to set that record correct for those who are picking it, because our country has a journey, and where we're going, there will be no corruption. Secondly, you had clapped for that. Maybe there's. Secondly, we have a emergency medical service policy and guideline where we have planned to procure Type B and Type C ambulances, 720, meaning every constituency will have an ambulance which is equipped to Type C level or Type B. The level of support in those two ambulances require having oxygen. At the moment, we phased out those which were like transport, car movement, and now we're at 312 in the country. So the journey is almost halfway. Thank you.
Thank you very much, Dr. Dan. We had a question on interesting financing mechanisms. I think you're directing it to Commissioner Fred. You know there are two Freddies. And then we had another on AI technology and cryogenic systems. So I'll request Engineer Byavagambi to comment about cryogenic oxygen in Uganda and how we are moving steadywise to include it in our mix, given the costs and efficiency issues.
Thank you very much. Before I talk about cryogenic, I just want to talk about AI. AI is already integrated in the monitoring of percentage purity of oxygen, and all is being done under what we call remote monitoring system. And all our PSA plants have this functionality, and we are able to understand the percentage of purity of oxygen so that our dear patients are able to get the required dose given the fact that this is now a medicine. Then cryogenic at NMS and Molago. I want to inform you that this has been already done. Installation has been completed, and the shipment of cryogenic liquid oxygen has already started, and hopefully in the first week of December, we are ready to start having this 60,000 liter oxygen plant functional, and also the 16,000 liter tank oxygen tank at Molago functional. So starting with December, these two investments, strategic investment, as a backup model, in case Space Air are not functional, December 2025, they will be now officially launched. Thank you.
Thank you very much. We are now getting to the closing of this session, very interesting session. We'll have 1 minute for each panelist, and then Prof. Reddy will come in. He will also answer the question on financing before inviting Dr. Chavainze to close the session and launch the report as I pass the copies around. So please, panelists, if you have 1 minute, any take home for this. If not, we can move on. At least we have to hear from Arthur. Yeah. one last message, and then maybe Robert, Stefan, 1 minute.
Okay.
Yeah.
All right. Thank you. As a frontline, as a clinician and a clinician scientist, I want to thank everybody for participating. I want to thank the Ministry of Health for its leadership in a lot of the oxygen, the development plan as well. And I also request the ministry to continue to lobby for more funding and resources to ensure last mile delivery to the patients in and around the country. And I thank everybody else for attending. Thank you.
I thank you very much. Blasio, the youngest panelist, you have to, you're going to be here longer than many of us.
Thank you very much. I'll want to emphasize government-led efforts in all these strategies that we're putting in place. And that means that our colleagues on the government end have to ensure that they step up and take up this responsibility. Yeah.
Thank you very much. Stefan?
No, thank you. Maybe just as a closing remark from our side, the one thing that I think is super important to emphasize is that the oxygen system fails fundamentally without reliable power. When we don't have reliable power in our health facilities, the oxygen equipment that we've invested in doesn't work. And even though some, like concentrators, maybe have a backup battery for a few hours, fundamentally, we need reliable power as an enabler to allow the oxygen infrastructure to work. So really, we need to think about, as we invest in oxygen, simultaneously looking at renewable power solutions, backup power solutions for our health facilities as well. Thank you.
Thank you very much. Yes, Dr. Sechitolego.
Yeah, thank you. I think just like we can see from this panel, to work, we need to work with different stakeholders and different players. I can design and get you the best technology out there, but if we do not have these different players doing their part, things are not going to work. So I think I encourage people to read this. It's not a very big book, so we can read and appreciate what's what the findings are. Some of it has been presented, and then see what can we contribute. I believe we are all here because we are interested in improving access to oxygen, and a great start is getting to get to be familiar with what's in the book and then see how we can collaborate to make things work better.
Thank you very much. Before I hand over, I just want to say that for many of us, oxygen is a personal story. For me, one of the inspirations I found for this work is from my grandmother, who passed away at a ripe age of 40 because of asthma, because she couldn't get to a hospital where she could be oxygenated. So the work that we've done and we are doing is very important, and sometimes it's not just the numbers you see. Many of us, it's one. It's the probability that you have a person affected by this is one. And with that, I thank you very much for being a good audience. I will thank the panelists, a round of applause for them. Yeah. And now I will invite the commissioner to answer any remaining questions and invite.
First of all, join me to thank Freddie for moderating the panel. And let's first also appreciate you for paying the attention, being part of this. And of course, the panelists, again, thank you for the wonderful time. There was a question from back in the room about financing options. I think part of the answers have come through. But what you'll find in the report is that the countries, but also you could say district, and you could also say hospital or health facility, need to get its appetite for a mix of these solutions. What you've seen at the country level, we are having cryogenic as a backup should these other things don't fall, but also we are trying to go beyond referral hospital to get to lower level health centers so that we can also find solutions that can work for that level. And we are trying also to pilot ways to pay. And I think this is what UNICEF has ably shared with us, trying to make oxygen as a service. In other words, find an entity that is going to be responsible for this unit and be given the targets and is paid for delivering those targets every often, as we'll agree. In other words, trying to move this responsibility from a busy health director, hospital director, which I think, as you know, sometimes is also an issue. So part of it is how do we get partners to try to support the set of solutions that we've selected. And that selection also needs to be informed by money available. But the report talks about that, selecting that, informed by what you have, but also trying to have a mix that allows you to have backup, to deal with power, and also to enjoy ourselves within an ecosystem of actors. Because what we do, even if you have a budget line approved as oxygen budget line, you still need to work with the industry in some way. So the industry also needs to find a way to finance what they are expected to bring to the party. In other words, we should look at this as a bigger system, and we are not only looking at what we can do within the health budget, within the facility, but otherwise we really need to convene the broader sector. You heard some sectors have oxygen as a byproduct. Okay, during COVID, we were given oxygen from roofings, and it was free. But picking it from there was the biggest problem because the cylinders became a challenge to find and to take. So, but if you know that there are these industries we can also bring to this ecosystem, you may find that in there are cost savings and financing becomes shared. But I'll stop on that question and come back to why we are here. We are here to give this report the impact it needs to have in your work, in the lives of those who need oxygen out there. And we think that all of you have picked one or two things that you can do and who you need to do it with. And we want to thank government and its partners for setting us on this course. As we shared, Uganda, we may have a few challenges here and there, but we are still far ahead in this area, and we need to celebrate that, and we thank our government for that. I heard from the opening session that they are against to protect or to, what is it, the word? Yes, they are against to to protect. And I think there are a lot in oxygen, and we would like to grow them, and we would like to invite you. As researchers also, you've heard, we do get a lot of information. But that information, and particularly writing a global commission as such, is really to influence various actors out there to make a contribution that acknowledges their role in a broader system. And we want to thank you. If you can take this message to wherever you are going, then we're sure that what we have in that report is not going to die there. There's a lot of things, you can't read it in a one go, it's not a novel, but I can tell you, once in a while you'll find reason to go and read a section because there is some important information. We also presented it with a lot of support so that the information is presented well, easy to capture, whether tables, whether graphs, or there's a lot of things you can see at a glance and run away and solve a problem. Thank you very much. Thank you. Have a nice day. Now I need to invite the director to send us home and to say last word. Sorry, I sometimes forget the protocol. These academics, some of us don't know how to deal with protocol. Director Daniel, please come and give us a few words. But also I want, as you come, to appreciate the leadership the ministry has given us in this area, and not only us as Uganda, but globally. And I know we've been part of that process. I remember seeing you at the World Health Assembly with the minister pushing this. Thank you very much.
The commissioners of this commission by the Lancet Global Health, Reducing Global Inequities in Medical Oxygen Access, the Lancet Global Health Commission on Oxygen Security. The panelists this evening, senior colleagues, ladies and gentlemen, boys and girls, good evening. I wanted to be as exclusive and inclusive in terms of both protocol, but to make sure nobody is left behind. If anybody needs oxygen, we need to find it. The beauty with oxygen, it was God-given, but in concentrations that we use when we are okay. When the body is giving way, we need to use the technology and the information delivered here to find solutions, to do the whole ecosystem to sustain the lives as long as life endures. So my conclusion, and as I commission and thank the people who worked tirelessly to produce this. By the way, this is very high quality publication. I want to congratulate the people who did it. Please, let's give them a round of applause. I want to say that, and I'll use their own statement, oxygen therapy is life-saving for people with acute illness, life-sustaining for people undergoing anesthesia and surgical care, and life-enhancing for people with chronic respiratory failure. Thank you for this gift to the world. I encourage everybody to use it, and I pledge on behalf of ministry, we are going to use it as a resource document. We want to take this opportunity on behalf of the Director General Health Services to declare and launch this paper and this book in Uganda. Thank you. You want a good proof, so let's all get our books and we stand.
So let's have the panelists and then the audience will join. Yeah? So the books.
Let's first give this one, and then there's a couple of more copies here.
So let's have the